for EMR in the stomach, but in fact, for us, we think that these small lesions of less than 20 millimeters are very good for ESD training for our young endoscopists, and therefore, for us, all these small lesions are kept for our trainees, and we do this kind of lesion under supervision, and now only with a traction-assisted ESD, even for the trainees. So this case was done by one of our fellows under supervision. It was a quite small lesions of the antrum on a gastric, on atrophic gastritis, just to show the current strategy we use for ESD in the stomach for the trainees under supervision. We do the circumferential incision and then the trimming. And after this, we put a rubber band and clip traction, even from the beginning, because in a previous study, we have demonstrated that the learning curve of people was shorter using traction from the early phase of training. So we more and more propose to the trainees to use this traction-assisted ESD, not from the early beginning. First cases are still in animal models, but as they begin to go to humans, we help them with the traction from the first cases. So for the early gastric cancer under 10 millimeters, ESD is now our first option, mainly to propose training for the first cases in human for the trainees of our units. For all the other cases without clear deep invasive criteria, ESD is our first option every time because of the very low risk of morbidity compared to surgery, but also thanks to this study from Portugal showing that the quality of life for people is higher without a larger fear of recurrence when we use ESD compared to surgery. The result in Asia was a little different. People were afraid of the recurrence in Europe. There is no additional fear of recurrence when we use ESD compared to surgery. So clearly, our first option is ESD. This is an example of a 66-year-old female who was a patient of my wife, who is a family doctor. She had abdominal pain and had a gastroscopy with only a small erosion of the antrum, and biopsies were done and describe a cancer without a clear description of a lesion. We took the patient, and in fact, we had 3 small demarcated areas, and we decided to resect all the area with the 3 small lesions in the same location by a single pieces. But unfortunately, despite the lateral R0 resection, you will see that ESD was not curative because this lesion was not differentiated, an undifferentiated type lesion with signet ring cell and a deep invasion of the deep margin, which was not free, despite the use of traction, and that we tried to be as deep as possible in the submucosa. I will be happy to discuss of this with you after to compare the technical points. And finally, unfortunately, it was a 2,300 microns invasion with cells on the deep margins. And the patient was referred for surgery, and unfortunately, she died from the surgery 1 week after the surgery from a septical adverse event. And I choose this example because, in fact, we follow the ESG guidelines that are based on the Japanese guidelines for all the curativeness definition of the resection. We are waiting now the last ESG guideline, which is on the point of being published very soon to have the last evolution of the Japanese guidelines applied in Europe. One point which is very important now in Europe is that traction becomes a standard for every procedure. So we use the recent randomized Japanese studies as a proof to spread traction for every procedure, but our first option is double clip and rubber band traction. And recently, we have developed more diffuse traction with 4 cardinal points traction. You will see on this example, because we thought that traction is a very important point to improve. But in fact, if we have a traction on the 4 cardinal points of the lesion, we improve again the speed of resection and also probably the easiness technically and the issues of the procedure. And in France, and I think everywhere in Europe, the duration of the procedure is an important limitation for ESD, and using technical tricks that improves the speed and reduce the duration to reduce the time of using the operating theater is probably not a good thing we should do without, and therefore traction and multi-traction are now used for quite every procedure to reduce the duration of these procedures. So finally, for the last case, when we think that the lesion is probably outside the curative criteria, we have 2 options. If the lesion could be a good candidate for ESD, we do the diagnostic ESD, and then we study the pathology report and decide if the treatment is okay or if we should go for further surgery or any other treatment. But if the lesion seems clearly deeply invasive, we go directly for surgery after extension checkup. Sometimes we still use EUS too precise for these borderline cases if we have a clear invasion of the muscle or not. But this is the only situation where EUS is still used to differentiate the lesions. And when we have a doubt on the invasion on endoscopy, sometimes EUS is used too precise, as I said. We do a diagnostic ESD, we study the precise histology, and if we have other criteria for the moment, surgery is clearly still the gold standard. There is no way for the moment in Europe for sentinel lymph node dissection and with a partial surgery. For the moment in Europe, it's more gastrectomy when we have this kind of over criteria lesion. So now we can say that we do traction assisted ESD for almost all cases except the clear deep invasive lesions. And for all the other cases, we do ESD, study the histology, and therefore decide if the patient is cured or not, and how we will follow him for the lesion itself, the risk of lymph node, and the metachronous lesions in the future. Thank you very much for attention.
Thank you, Mashu. Very, very wonderful talk about the European situation, especially in your institute. Actually, even if the lesion is small, ESD is applicable other than EMR because of the training of young endoscopists. And then it may be better to have the en bloc resection. And then even if the lesion has a possibility of deep invasion, EUS is not so good diagnostic accuracy, so diagnostic ESD will be acceptable. And then to make ESD speed up, first ESD, he make a new traction method by using rubber bands, and it will be very good to make first resection. Okay, and then there is a question from the audience: how to detect gastric cancer early in your situation? Would you?
Sorry.
How the main problem
is, the main problem is that we have no screening program for gastric cancer because it's rare. So unfortunately, the gastric cancer are found for any other reason, for symptoms or for something which is not linked to the gastric cancer, but more for the subsequent disease. So in fact, there is a part of chance in this detection, and probably the future for Europe is more something like a capsule with automatic AI detection of gastric cancer or something like this, because we will never, the patient will never accept to have an upper GI endoscopy for a so low risk of gastric cancer. It's very difficult to do the screening program for colon, despite the fact that it is a very frequent cancer in our country. So doing something like gastroscopy for something so rare seems difficult to imagine without a non-invasive test, which is more acceptable for people.
Okay. Maybe in the future, AI capsule will help to detect early gastric cancer in Europe. Okay. Okay, thank you very much, Matthew. Maybe we have time. We will make a discussion session later. Okay, thank you very much. Next speaker is Dr. Miguel Tanimoto. I will make a short introduction. He graduated from medical school, National University of Mexico in 1994. And from 1999, he is a board member of the Mexican Council of Gastroenterology and Mexican Council of Gastrointestinal Endoscopy. Since 2008, he became a fellow of American Gastroenterological Association, and then he became associate professor of the World Gastroenterology Organization Training Center, National Institute of Medical Science and Nutrition, Salvador Zubiran. And since 2016, he became our vice director of ancillary and diagnostic service of the National Institute of Medical Science and Nutrition, Salvador Zubiran. And then since 2017, he is a member of Digestive Cancer Committee from the WEO. And then since 2020, he is a member of Webinar Committee of WEO. His talk today is endoscopic treatment of early gastric cancer from American perspective. Please start your talk.
Thank you, Professor Fuyishiro, for your kind introduction. And good morning, America. Good afternoon, Europe. And good evening, Asia. Thank you for this opportunity to present this topic, endoscopic diagnosis and treatment for early gastric cancer, American perspective. I want to thank Dr. Fuyishiro for this kind invitation, and I share with you that I have no conflicts of interest in this presentation. And I want to thank Dr. Kakushima for her hard work in the international proposal for the diagnosis and treatment of gastric cancer. As you know, there are different well-known risk factors that are involved in gastric cancer. Within all the subtypes of gastric cancer, only 10% are of early onset. They are patients younger than 45 years old, and it is probably in this group that early gastric cancer can be studied in a better way because they have had a shorter time of exposure to external factors. For prevention strategies, a better diet and the eradication of H. pylori have been well identified, and endoscopy as a detection strategy. It is well known that there is a delay in the diagnosis of gastric cancer. Since the first symptoms appears, this is the period of time that corresponds to the patient when he complains of stomach pain or significant weight loss, until he visits the doctor and there is the first clinical evidence, such as melena or hematemesis, the primary care doctors orders for the first time basic laboratories and imaging studies. This is the time interval that corresponds to the primary care system, and then the patient is referred to a specialist, and this is the time interval corresponding to the highly specialized system. As you can see, the time to establish the diagnosis of gastric cancer takes a long time, in such a way that when it reaches to the high specialty hospitals for define a strategy to treat the patient, the gastric cancer is found in an advanced stage. According to the Global Cancer Observatory for the World Health Organization, it represents the 5th cause of cancer in the world, and the 6th most common cause of cancer death. There are regional differences in the diagnosis and treatment of gastric cancer. In Japan and South Korea, an incidence of 26.9 per 100,000 is observed. More than 50% of the cases are diagnosed in an early stage, and less than 20% are diagnosed in an advanced stage. When comparing with Mexico and the rest of the Latin American countries, unfortunately, the epidemiological information is incomplete, and less than 5% are diagnosed in an early stage. There are few attempts or no screening programs for gastric cancer. Despite this incomplete epidemiological information, this group of Mexican epidemiologists had studied the causes of mortality by type of cancer per 100,000 inhabitants of Mexico between the years 2000 and 2013. In men, after prostate and lung cancer is the 3rd cause of death, and also in women after cervix and breast. Initially, the criteria for endoscopic treatment of early gastric cancer only considered intramucosal lesions that did not invade the lamina propria. However, because these criteria were too strict, afterwards, extended criteria were developed to also consider lesions that invade up to the first third of the submucosa. It is important to note that there is a risk of lymphatic invasion between 9% to 19% in lesions that invade between M3 and SM1. And lesions that invade SM3 cannot receive endoscopic treatment and must be referred to surgery. ESD blades are essential to have success and avoid complications in this procedure. In this figure, you can see a comparison of the contact area cutting power and coagulation power between different blades. Depending on the location and type of lesion, the knife is selected according to the preferences of the endoscopist. Also, if necessary, a combination of knives. Here you can see some examples of endoscopic dissection knives. Unfortunately, even in Canada and the United States, not all the types of knives are available. In Latin America, for example, there are only 1 or 2 of these knives available. For this reason, sometimes these devices had to be sterilized and reused. Also, the submucosal solution is crucial for the success of ESD. For this reason, multiple attempts have been made to reproduce the ones that are available in Asia. I use a solution with saline, indigo, and epinephrine. According to the Japanese series, the piecemeal EMR, there is a recurrence that goes from 2% to 35% when comparing against en bloc ESD. In this table, you can see that for the EMR, the patient is ambulatory, and it is a simple procedure, which is carried out in less than 20 minutes, and adverse events are infrequent. Compared to ESD, where the patient sometimes remains in hospital for more than 24 hours, it is a difficult procedure that requires training and experience, and the time of the procedure depends on the type, size, and location of the lesion. Also, adverse events are more frequent. Because EMR is relatively easy, this technique has been preferred in America. In this table, you can see the EMR techniques, and recently several Western studies had reported that with ablation of the edges after piecemeal EMR, recurrence could be prevented. But unfortunately, EMR is indicated for lesions smaller than 13 millimeters with mild dysplasia. With this mesh, I have found in PubMed 1,246 references from the countries that you can see in the image. This is a study from the year 2016 that investigated ESD practice in Central and South America through an electronic survey and additional PubMed search, in which 37 endoscopists from 23 centers distributed in 10 countries answered the survey, and 67% had performed ESD. 92% was trained with porcine models, and for the 10 countries, a total of 723 ESD was carried out. The average number of ESD performed per endoscopist was 29 in these regions, and 9.2% of complications. With this mesh, I have found in PubMed 7 countries from America that have guidelines for the diagnosis and treatment of gastric cancer. These are the guidelines from Mexico for the diagnosis and treatment of gastric. This consensus produced 38 recommendations. And this is the international proposal, thanks to the hard work of Dr. Kakushima and Dr. Fujishiro, with the aim of supporting countries that still do not have guidelines. And this is a typical clinical case of early gastric cancer diagnosis and treatment of a 57-year-old man. His labs without abnormalities, negative family history, and during a surveillance endoscopy in random biopsies, an endoscopist found an in situ carcinoma. And in the physical examination, no abnormalities were found. As you can see here, all the values for the laboratory are in normal range, and also he was negative for H. pylori. In this image, with conventional white light endoscopy, no tumor or bleeding site were observed. But when using magnification with blue laser, as you can see, we can identify the neoplastic lesion with poorly defined borders with magnification, as you can see here. After having reviewed the histopathology, also videos, laboratories, and PET-CT, the diagnosis of a type 02B plus 2C lesion, and after informed consent was signed, the ESD was performed, and the patient was discharged from the hospital the same day after procedure. With LCI, we can characterize better this lesion. Using dual knife, the margins were marked, and submucosal lifting with saline indigo and epinephrine. The ESD was performed with dual knife and using the fishing line techniques to elevate the lesion for better visualization of the dissection plane. Finally, with a 92 knife, the last cut was performed. Lastly, I checked if there were any bleeding or other complications. The specimen was then fixed on a cord indicating the oral site and immersing a formaldehyde for 24 hours. The pathologist reported an in situ carcinoma with free vertical and lateral margins. I want to present, this is a small study from my private practice, and between January 2017 and November 2019, I have found 17 stomach early gastric cancer lesions in 18 women and 22 men. The average age for the patients was 59 years old, with a range of 41 to 84 years old, and these were the most frequent sites where the lesions were found. The average size of the lesions was 23 by 33 millimeters, and shown in the graph are the width and length of each lesion. 115 minutes was the mean time for this procedure. In the graphic, you can see the time of the procedure for each lesion. More than 50% were flat lesions, and block resection was achieved in 100%. More than 70% were neoplastic lesions, and en bloc resection with negative margins was achieved in more than 90% of the patients. As you can see in this table with several Japanese series, the results of this small study of my private practice were consistent with the reported Japanese series. Thank you very much for your kind attention, and I hope that you have a lot of questions to have the conclusions of my presentation. Thank you very much.
Thank you, Miguel. Very wonderful presentation. Actually, you start from the risk factor of gastric cancer, and then how to, detect your gastric cancer, and then how to treat this region in ESD in American situation. I'm very surprised that you don't have enough equipment to perform ESD, such as a small number of knives, or you don't have the glycerin solution or something. We Japanese usually use these things, so you may have a lot of trouble to perform ESD, but your result is very wonderful, 100% en bloc resection, right? And then maybe you performed a very nice ESD in Mexico. Okay, actually, we have the question from the audience. Professor Tomoki Michida make a question. What is the most important for ESD training?
I think that the most important fact for ESD training is the teamwork. Because
teamwork.
Yes.
Good.
Because yes, of course, if you don't have a good team, you cannot perform any ESD, and you have to train your nurses and your assistants in order to work as only one man. And sometimes when you are practicing ESD, you need more than two hands. And of course, by the traditional endoscopes, we don't have the we have only the traditional endoscopes with one working channel. So sometimes it's as a surgeon with one hand. And that's why the fishing line technique is very, very useful. And I haven't used rubber bands. It's also a very clever technique, as the Dr. Piochet showed us. But the fishing line is also very convenient technique. And I used to use this technique with the fishing line at the very end of the procedure, because otherwise you will have a lot of trouble if you try to anticipate the use of the fishing line. So I think the teamwork.
Teamwork, okay. And then maybe traction method is also very important, right? And then One question from the audience. For RE detection, is there any role of FICE mode or NBI mode or EUS or something? How about your image-enhanced endoscopy for RE detection of gastric cancer? What's your opinion?
Yes, it's a very nice question. Of course, I was trained in Japan as everybody, but we don't use EUS, or at least I don't use EUS, because we are confident in our eyes, and because of that, by our eyes, we can determine the submucosal invasion of a lesion, and of course, the enhanced endoscopy image and magnification, and also the use of NBI, FICE, and blue laser is a very important fact in order to diagnose the deepness of a lesion. Also, when you have an undifferentiated cancer type and you have a whitish lesion in the stomach, it's very, very difficult to diagnose correctly and also to define the margins. So unfortunately, you need magnification and NBI and blue laser or FICE, yes.
Okay, thank you very much. We have a lot of questions for you, so please answer in the Q&A parts. Actually, thereafter, I'll move on to the next speaker. Okay, thank you very much for your wonderful presentation, Miguel. Thank you. Okay, last speaker is Dr. Shannon Chang from Hong Kong. And I'll introduce briefly. Dr. Shannon Chang is currently an assistant professor in Division of Upper Gastrointestinal Metabolic Surgery of Chinese University of Hong Kong. Dr. Chang's interest is in gastric and esophageal cancer, mainly focusing in laparoscopic and robotic approach. She's a surgeon, but she's also interested in maybe ESD or endoscopic treatment, of course. And she did overseas training in National Cancer Center in Tokyo and Yonsei University in Seoul, and also Amsterdam Medical Center in Amsterdam. And she is very talented endoscopist, a lot of publication in the endoscopic journal. And today she will make a presentation about endoscopic treatment of early gastric cancer from Asian perspective. Shannon, please.
Thank you very much, Professor Fujishiro. So thank you for the invitation. So my name is Shannon, and as the professor has introduced, I'm an assistant professor and a surgeon, mainly focusing on gastric cancers and esophageal cancer. So in Hong Kong, surgeons also do MBI-OGDs and do advanced endoscopy. So I'm the last speaker, so some of the information might have been mentioned in the talks before, so I hope I don't replicate too much. So according to the global CAN data, gastric cancer is the fifth and the fourth leading cause of cancer-related mortality worldwide. And if you look at the high-risk areas, Eastern Asia, including Northeast Asia, including Korea, Japan, Mongolia, China, and part of South America are high-risk regions. And if you look at this incident graph, as the incidence of gastric cancer increases, the majority of the cases are actually in Asia. And according to the incidence and the epidemiology in the past years, we know that in Eastern Asia, we have more highest incidence of gastric cancer. and also together with the highest mortality. And as we all know, in Japan, where ESD was first performed, and also all the early diagnostics for early gastric cancer, the number of endoscopic resection has actually surpassed the number of gastrectomy in their national database in 2017. And the reported 5-year survival for gastric cancers are the highest in Korea and in Japan. And if you look at this graph, you can see that in South Korea, the incidence of early gastric cancers is rising, and it rises together with their 5-year overall survival for gastric cancers. So when we talk about the Asian perspective, I'm a little bit embarrassed to be talking about this because Hong Kong, actually, the incidence of gastric cancer is very low. So as low as in the United States or in America. So actually, when we talk about Asian perspective, it's more of Japan and Korea against the entire world. So I'll take the opportunity to share with you what our Japanese and Korean colleagues have published on the literature on the management of early gastric cancers. And of course, we all know early diagnosis is the key to improving survival outcomes of these gastric cancers. And if you can see, there is actually an early gastric cancer seen on this picture on the right-hand side. So the flow of management of endoscopic treatment for early upper GI cancers, first, of course, we need to detect the early gastric cancers, and we need to detect them especially in cases with high risk. So precancerous lesions include atrophic gastritis, intestinal metaplasia, and H. pylori-related gastritis, which can be seen on MBR OGD. And this can only be done with an advanced endoscopic diagnosis, including narrowband imaging, blue light endoscopy, LCI imaging, and also the latest TXI modalities. So after assessing the indication and the staging, we perform the EMR or ESD. So afterwards, with the pathology, we will know whether it was a curative ESD, and depending on that, we offer follow-up surveillance endoscopy, or we offer salvage surgery if the resection was not curative resection. So because the topic I was given was treatment of early gastric cancer, so I would focus more on this. So the indication of endoscopic resection for early GI cancers has several prerequisites. So first, an en bloc resection has to be done with negative resection margins. And this is important so that we can accurately predict the chance of lymph node metastasis. And this is based on both the pathological assessment and also a detailed pre-resection endoscopic assessment. So we should all be familiar with this guideline and indication for ESD as published in the Japanese gastric cancer guideline. So for the blue part, it's the definite indication guideline for ESD. So it's a differentiated type of cancer that is less than 2 centimeters that does not have an ulcer. For the orange one, it's the expanded indication, and all the white ones are out of resection criteria. So how did the Japanese come up with all these guidelines? So the first ESD was actually performed in the early 2000s in Japan, where the en bloc resection of gastric mucosal tumor was performed. And over the years, as Miguel has pointed out, there were different special ESD-specific devices, including the IT knife, Do knife, TT knife, and they all do have their own specific indications. And usually we need to use a combination of them together to make fruitful and successful ESD. So when we talk about the guideline and indication of an ESD, first we need to assess whether we can achieve an en bloc resection. And second, we need to know the overall survival and the chances of lymph node metastasis. So in this study, they tried to look at the overall survival after ESD according to different criteria. So including the NCC criteria, the JGCA criteria, and the expanded NCC criteria. So they followed their group of patients for 44 months, and they found that with the normal guidelines, the 5-year survival was 92. Even with the expanded guidelines, the survival was over 90. And even with multiple metachronous tumors, the 5-year survival is very, very satisfactory, and with only one gastric cancer-related death. So with this study, it proves that the guidelines is actually well defined, so that the 5-year survival rate is very high. So then further studies have been done to validate the expanded criteria within that box we saw just now. So in this JCOG 0607 trial, they specifically looked at the expanded indication for tumors that are well differentiated, that are more than 2 centimeters or less than 3 centimeters, but with an ulcer. So even with this expanded indication, the overall 5-year survival was 97. So again, validating this specific expanded criteria. As for tumors that are undifferentiated and less than 2 centimeters without an ulcer, this other JCOG trial also proved that the overall 5-year survival was over 97%. So all these guidelines actually have all these non-randomized trial to back up with statistics showing that even in the expanded indication, the 5-year survival is more than 95%. So with this, this is the JGIS most updated guidelines. So including all the previous study and the expanded guidelines, this is now the latest indication for ESD. So the star box is also an indication for EMR. So we had discussions in previous lectures today about the difference between EMR and ESD. Of course, EMR is less technically demanding, but if you do look at the en bloc resection rate, the EMR is almost half the percentage as compared to ESD, and also the on-out resection rate is much lower. The recurrence rate, on the other hand, is much higher. And in this single-center study by Professor Uedo, you can see that with EMR, the curative resection rate is actually much, much lower than ESD. So with this, I would like to conclude with the Japanese data. ESD is recommended for early gastric cancers in most circumstances. So I believe previous speakers have already talked about this traction technique. So as the ESD technique begins to improve over the years, one of the landmark techniques was to use the traction for ESD, and which makes life so much more easier when you have a traction, because as we learn as the surgical trainee, traction and counter traction is the most important in all resections. So with this traction technique, they published this RCT, multi-centered RCT on conventional ESD versus traction-assisted ESD, showing that the perforation rate is much lower and actually much shorter resection time, especially when the tumor is located in the upper greater curve. So everyone will agree that this traction technique is one of the most important landmark improvements on the ESD techniques over the recent years. Another important guideline in the JGIS guideline is how to handle the specimen after resection. Because pathological assessment is of utmost importance to determine the curability of your ESD specimen. So handling it properly is actually very important. So the guideline states that after the specimen is resected, you need to pin it down flat on a flat surface so you can actually macroscopically see the resection margins. And if you cannot fix it in formalin immediately, you have to keep it moist in a normal saline. And after pinning it down, you have to process it in 2 mm cuts, so then the specimen can be detailedly assessed by experienced pathologist. So with the pathological diagnosis, then we can look at the eCura system, which is a scoring system for the curability after ESDZ resection. So the rationale behind this eCura system was from a very, very large database, which the developmental cohort actually came from patients who underwent radical surgery after an ESD where the curative criteria was not met. So a small number of them underwent observation and surveillance only, and this was became the validation cohort. So according to this study, they developed all the risk factors according to tumor size with 3 centimeters as a cutoff, tumor depth with SM2 mucosa and SM1 as one group, histological subtype, lymphatic invasion, venous invasion, ulceration, and vertical margin. So you can see that lymphatic invasion plays a very important role with the highest number of points. So with all these points, then you get a score. And with the score, you know the rate of lymph node metastasis according to that database. So in cases of eCura C2, which is a more advanced, higher risk score and a high number of high rate of lymph node metastasis, gastrectomy should be offered as a standard. So according to the JJS guidelines, after the resection of ESD, you can divide your patient into the eCura A, B, and C group. So AB, only surveillance is required. For C1, you can either offer surgical resection or repeat ESD or careful follow-up. For eCura C2, because of the high rate of lymph node metastasis, surgical resection is suggested. So to be specific about the Asian population is how to deal with the elderly patients. So ESD now has become quite a routine and standard with all the indications and techniques. But as the world, and especially over Asia, where life expectancy is increasing, and you can see that in Asia, the world's longest life expectancy is in Hong Kong, second is Japan, followed by Macau, and the 5th is actually Singapore. So top 4 countries in the top 5 that's actually in Asia. So we, especially in surgical stream, we need to deal with octogenarians a lot of time. So how does ESD and gastric cancer stand in these older patients? So there are actually quite a number of studies, 17 in total, trying to address this question. So the question is whether these patients would benefit from ESD resections. So will they die of non-gastric cancer related deaths more, or will they die of gastric cancer itself? So in this study, they try to address ESD in patients who are aged 85 or above. And in a very elderly group, meaning more than 85, of course, the overall survival is significantly worse as compared to the non-elderly group who are less than or equal to 64 years old. And those with cardiovascular disease has worse prognosis. And if you look at the reason for their mortality, the gastric cancer-related mortality is actually 0 in the very elderly group. So it makes you question whether ESD should be performed in this very, very old group. Another question is that if you do an ESD in an old patient and it comes back to be a non-curative ESD, should we offer additional gastrectomy? So does it affect his survival even there is like a 20% chance of lymph node metastasis? So in this study, they studied 87 patients who are over 75 years old with non-curative ESD. So only 30% had gastrectomy done. So they evaluated the risk factors of their deaths, and they found that Charleston Comorbidity Index, which is something we use surgically to assess the patient's fitness for surgery and their risk for mortality after surgery. The higher the score, the higher risk you are. So a score of more than or equal to 3 is risk factor for mortality. So perhaps in these cases, some additional gastrectomy should not be performed. In another more recent study that is actually just published this year, the question this paper addressed was that is additional gastrectomy required for elderly patients after ESD for C2 pathological assessment? So the question you need to ask yourself is that now you know that the patient is ECURA C2. So what is his risk of gastric cancer specific mortality as compared to the non-gastric cancer related mortality, and how is the quality of life for this patient? So as you can see here in this pyramid, this is the ECURA system that has been mentioned. So the C2 actually has the highest risk with a 22.7 lymph node metastasis rate. So the conclusion of this study was that, of course, for ECURA C2 non-elderly, gastrectomy is the standard of care. But for elderly, you need to perform a comprehensive geriatric assessment with a combined evaluation risk of the gastric and non-gastric cancer-related mortality and quality of life before you can make that decision. So another controversy that is currently still being answered is after a successful ESD, should we or should we not close the defect? So there are actually different ways to close the defect. So either use the overstitch, which is seen here with the Apollo system. It is quite cumbersome to use, and you can either use a dual channel or a single channel scope, which requires some learning curve to get hold of this instrument. Or you can use a clip loop method, which is using the detachable snare and multiple clips to close the defect, or with the newer rubber band method as previously mentioned. You can also use the endoscopic hand suturing, which was developed in Japan. So surgeons actually find it very attractive because this endoscopic hand suture is very similar to surgical suturing, where a needle holder is placed through the channel, grasping this suture. This suture actually has some flaps on it, so then it will automatically lock itself once you pull it through a tissue. So you can see that ergonomically it's very sound, so it can grasp large amounts of tissue. And it's actually very similar to how we do laparoscopic suture. But I'm sure this is much more difficult than it looks because you're working with one hand and there is no traction within this. So this paper was published 2 years ago. It was a multi-center pilot feasibility study on the use of this endoscopic hand suturing. So the defect they included were around 3.6 centimeters, and they required around 15 minutes to close this defect. So these are one of the techniques that is in evaluation. So another technique to close these defects is a new device called the X-Tac closure. It's developed by the Apollo system too. So the good thing about this device is that you do not need to change your scope. So this is just a normal HQ290. This procedure was performed after I did an endoscopic full thickness resection, but the way to close it is the same. So basically, this suture is connected to 4 screws. So when you put your screw in the correct position, the nurse who holds this will turn the blue knob, and then the screw will automatically screw in the mucosa and submucosa as you see here. So it's turning in. So and then the nurse will pull back. So if you think that it hasn't grabbed enough tissue, you can turn it for one more round. So you can drill it in. Or if you think it's okay, then the nurse can let go of this drill, and you can pull out this suture and anchor the second suture. So once you get the tag, you put it in the right position, ask the nurse to turn the knob, drill the screw in. As you can see here, the tissue is being grabbed into the screw. So you repeat this procedure. This suture actually has 4 tags. So you can put it at 4 tags in a zigzag manner. So once you close it, then the defect will be all pulled together. So the last step of this X-Tack closure is quite similar to overstitch, where you exchange the previous device out and insert the singe. So this singe is the exact same singe that is used at the end of an overstitch procedure. So here you can see our the 4 tags that were previously placed. So with a movement of both your left hand and right hand to close the defect and tighten the tension, then you can fire off the singe. And this is what it looks like after the closure. So this was full thickness resection. So whether to close the defect or not is now still controversial. Of course, the pros is that it reduces the adverse events after ESD, especially delayed bleeding. But of course, it's also time consuming. And the device used to close it can be very costly. And sometimes when resection margins are uncertain, you may be embedding tumor into the submucosa. So current suggestions is that this is only indicated in patients who are at high risk of adverse events, such as patients who are on anticoagulants or undergoing a wide field resection in the right side of colon or in the duodenum, or ESD done in the same day surgery, particularly in countries where hospitalization is expensive. So in order to address this important question, another study also published by our Japanese colleagues attempted to do this prediction model to let us know which patients are at high risk for bleeding after ESD. So with this, a prediction model, you also have several points. So if the patient is on warfarin or anticoagulants, you get 4 points. Chronic kidney disease with hemodialysis, you get 3 points. And with this, they made a prediction model, which they have shown to demonstrate good discrimination and good calibration. And this is called the best J score. So perhaps with the high best J score, the defect should be closed. So in conclusion, ESD for gastric cancers are the standard of treatment for early gastric cancers, and it is important to detect them early. And currently, the controversies that we are still trying to figure out is that with the entire world aging population, we need a better prediction model for survival and selection of cases. And with the increased use of anticoagulations, we need to investigate which patients are indicated for closures of ESD defects. Thank you.
Thank you, Shannon, for your very wonderful, comprehensive talk. And we understand the situation in Asian countries, especially Japan. Your data are almost from Japanese colleagues, and you introduce our Japanese guideline. Actually, additionally, you make a wonderful talk about closure technique by using hand suturing and X-Tack closure, which will be applied in the complicated cases, making there such a postoperative bleeding or the perforation or something. And our Asian situation is becoming very aging population. And our Japanese data, actually the 80% of gastric cancer over 65-year-old, and then 40% of patients are over 85-year-old. So we can maybe expand our indication, or we can make a more wider indication or endoscopic treatment. Okay. There is a question from the audience. What is the meaning of letters like P or C before the T stage? These are maybe pathological or clinical. pathological means that after resection, we check by pathologically, and C means that before endoscopic resection, we can make a diagnosis of the lesion. Shannon, you are a surgeon, right? Which is your preferable technique, wrap surgery or ESD?
Well, it depends on the indication. I guess ESD, the patients actually recover much quicker, and we don't really have to worry about anastomotic leaks or duodenal stump leaks or anything, or internal herniations or things. So ESD is actually quite more straightforward with less complications. So I would feel more comfortable with doing after an ESD as compared to after a gastrectomy.
Actually, what's the indication of ESD? You strict the indication in the Japanese guideline, or you expand the indication of ESD?
Oh, we use the expanded indication. So if we're not sure, we just do a staging ESD, and we can just do a salvage gastrectomy if it's a non-curative resection.
Okay. There. Time is nearly up, but I'd like to make one question for each speaker. Actually, I would like to know how to train ESD in your lesion. Actually, how to train the young endoscopist to perform ESD in your lesion. From Mathieu, please say again.
So in France, we are following the European Society Gastrointestinal Endoscopy curriculum. Our society have defined a minimal training curriculum to get a kind of license to perform ESD, and therefore we have created in France a 1-year training program with the theoretical knowledge training, and after 1 week of animal training before a training in human with a tutor. Each candidate of the training program have to declare a tutor to do the first 10 cases under supervision, and to be trained progressively from the first case to the 10th one. So it is organized now in France.
Okay, thank you very much.
Through the French Society, sorry.
Okay, and then how about Miguel?
Oh, thank you for your question. Unfortunately, in Mexico, we don't have a formal training program on ESD, but I think the better way to train young endoscopists is first with animal models, afterwards watching the expert, and afterwards helping the expert, and finally being assisted by the expert. I think that these 4 steps are crucial, and as I told you, the teamwork is very important because you need to train your nurse, your assistant, and you must have all the technology ready to be used in the very moment, I think.
Okay, thank you. How about Shannon?
So I guess in Hong Kong, we also, as like in Mexico, we do not have a very specific training program. But because ESD actually was brought in by Professor Philip Chiu in our center, so we actually follow strictly the NBIC workshops. So all our trainees first have to do very good advanced diagnostic endoscopy first. So they need to recognize the lesion first, and then they get on pig models to train, as with the NBIC workshops, and then it's then an apprenticeship. So they follow Professor Chiu or one of our seniors to do a certain number of cases. So they start with gastric, then they move on to colonic ESDs, and then to duodenal ESDs. But we do not really have like a fixed number. So we depend on the trainee and how they go and determine whether they can move on to the next step of performing the procedures.
Okay, thank you very much. Actually, if you want to master ESD, it's better to go to their center to perform ESD and maybe have the good mentor to find out to perform the ESD. Actually, there in Japan we have several centers who have the foreign trainees, and of course in Hong Kong, France, or Mexico, you may have such a program to train the younger colleagues to perform the ESD, maybe, right? Okay. As a closing remarks, I will make some presentation by using slides. Actually, today, I'm very happy to have 3 wonderful speakers from a different region in the globe. Actually, Matthew presented from European perspective, Miguel, American perspective, and Shannon from Asian perspective. Actually, this is a Japanese situation I will mention. And stomach cancer is second most common cancer. And then in terms of incidence, and in terms of death, third most common. And then now we have a lot of cases of endoscopic resection. And then from these data, actually around 41% of gastric cancer are treated endoscopically. This is a Japanese situation. And then again, from the national database, wonderfully, we can have more endoscopic resection cases than surgery from 2016. In surgery cases, there are advanced gastric cancer, so we detected very early stage and we treat by endoscopically. This is our Japanese situation. So early detection is the most priority to perform the good quality of management by using endoscopy. Actually, I will step down from the chair of the Stomach Duodenal Disease Committee this spring. Very thank you for all the committee members, including 3 speakers. And during my term, as Miguel presented, we published a paper about the principle of the practice of facilitated complete photo documentation of upper GI tract like this to detect early gastric cancer. And then additionally, we make a publication of proposal of minimal elements of screening and diagnosis gastric cancer by international Delphi consensus. Actually, this is a summary of recommendation as shown in this slide. Actually, if you are interested in, please read this paper. You can see freely, you can download from the internet. Actually, as a Japanese endoscopist, welcome all of you to our JGS and WEO meeting in May, next May in Kyoto. Unfortunately, for foreign doctors, it is very difficult to join in person in Kyoto, but if you have an internet connection, please join our meeting held in Kyoto. Okay, thank you very much for your kind participation in this webinar. Thank you very much.
Thank you.
Thank you, Professor.
Thank you.
Thank you.